Hello and welcome to the Evidence-Based Urgent Care Urgentology Podcast. I'm Joe Toscano. I am on the editorial board of Evidence-Based Urgent Care and also the senior research editor for the sister EB Medicine publication, Emergency Medicine Practice.
And I'm Tracy Davidoff. I'm the editor-in-chief of Evidence-Based Urgent Care. Joe and I have been involved in urgent care practice and education for many years, and we're really excited to bring to you this new program from EB Medicine, the Evidence-Based Urgentology Podcast. Our goal for this podcast is to review one of the recent issues of evidence-based urgent care and highlight some of the important things that have come out of that issue, the learning points and potentially practice-changing information from the piece.
We hope that the podcast will be valuable in and of itself, but it'll also whet your appetite to delve more deeply into the issue, to hone your practice and even get some CME credit.
And even if you've read the issue already, Joe and I hope to reinforce the important points and solidify important concepts to improve your learning as a result.
If you create an account at ebmedicine.net, you can subscribe and purchase the issue. You can check out the interactive clinical pathways they have there, and you can get up to 4 hours of CME credit for completing this one issue. Hey, you've already started your CME journey by listening in.
And you can also subscribe for a full year so you won't miss anything. At the regular price, that's a great value. Be on the lookout for occasional promos, sales, and special offers to make it that much easier.
Well, welcome everyone. Tracy and I are here together this month to talk about the July issue of Evidence-Based Urgent Care entitled Managing Shoulder Injuries in the Urgent Care, Fracture, Dislocation, and Overuse. We'd like to thank our authors, Mary Balagapudi, also Dr. Michelle Wilson, Hope Ring, and they are all from the University of Kansas Department of Emergency Medicine. Our peer reviewers for this issue were our very own Krista Charno, as well as Dina Eldiger and Michael Pond.
Awesome. Yes. Well, shoulders are a common topic, and a lot of people have, I don't want to say issues or trouble with it because understanding the anatomy and the mechanism of injury to shoulders is kind of difficult, but it's also a lot of overuse injuries and a lot of work-related type injuries and things that are kind of nebulous sometimes. We do see a lot of this in urgent care, and if you do some occupational medicine, you'll realize that there's a ton of occupational medicine-related shoulders, and in fact, it's actually the third largest chief complaint in workman's compensation claims. So big topic. We've got fractures, we've got dislocations, we've got a lot of soft tissue injuries and a lot of chronic problems. So trying to sort this out and tease it out sometimes can be a little bit difficult. The importance of it is making the right diagnosis and referring them to the right person for the right evaluation and treatment, because if you miss something, you can result in chronic pain. There could be some permanent disability involved and a lot of other complications like arthritis and things that may be a long-term complication and disability for the patient. So fractures and dislocations, pretty relatively straightforward. You know, if it's broken, obvious. Dislocated, also pretty obvious. But the soft tissue and overuse injuries may be more confusing and difficult to diagnose. So this issue will hopefully help sort that out for you. I urge you to reference the issue itself. We had some great photos in there about anatomy. There's some good charts about the physical testing and maneuvers. And as we'll talk about a little bit later, there's a ton of them. And there's also some flow charts on how to manage these conditions. Let's start out with some anatomy. Joe, can you review that for us?
Sure. Yeah, shoulder joint is actually one of the more complicated joints. Most of our joints are simple hinges, kind of back and forth, two bones touching, range of motion only in one plane. But the shoulder is one of our most flexible joints, which puts it at risk for a lot of the stuff we're going to talk about in terms of disorders. It actually includes 3 bones and 3 joints. The bones are the clavicle, the humerus, and the scapula. I think most of us think of the glenohumeral joint as the quote shoulder itself, but we also need to consider the other 2 joints, the sternoclavicular joint and the acromioclavicular joint. Shoulder's kind of interesting. It's kind of out there floating. The clavicle acts as an outrigger for it almost, or kind of a supporting structure. There's actually a 4th connection. It's the scapulothoracic connection where the shoulder blade is connected to the back of the torso. We don't see a lot of injuries related to that don't directly involve the scapula itself, like a scapular fracture, but it's another consideration, another connection that helps support the shoulder and allows its flexibility. Of course, there are many muscles, tendons, ligaments, and a couple of bursa in there that can have problems associated with them. The incredible mobility of the shoulder comes from its shallow socket, allows it to move anywhere except against the body. Basically, that shallow socket makes it easily dislocated, and then all those supporting structures are subject to injury as well. The shoulder is not really held together by tight ligaments to allow its flexibility. It has a dynamic stabilization system, and that's the rotator cuff. The rotator cuff basically contracts and holds the shoulder together as it moves in different planes. four muscles of the rotator cuff, the supraspinatus, which is probably the one we see injured the most. But there's also the infraspinatus, the teres minor, and the subscapularis. A lot of us memorize that as the sits muscles, supraspinatus, infraspinatus, teres, subscapularis. I can think of at least three bursas in the shoulder, but occasionally I'll hear an orthopedist talk about a bursa that I never heard about before. There's basically the subdeltoid subacromial, and then there's a little bursa under the proximal biceps. And then, of course, all kinds of neurovascular structures, arteries, veins flow through there. And brachial plexus is medial to the shoulder joint. Nerves travel under the scapula. And all of those can be injured or affected by injuries or disease processes in the shoulder.
Yeah, I never realized how disabling a shoulder injury can actually be until I broke my own shoulder. So can't feed yourself. You can't do most of your ADLs. Sleeping is incredibly difficult to try and find a good position that doesn't put stress on that shoulder joint. It was definitely a rude awakening, injuring my shoulder, finding out how disabling that really could be for someone.
Sure.
So let's talk about the differential diagnosis. Injury, obviously pretty straightforward. Either you injured your shoulder or you didn't. Soft tissue injuries, trying to discern that between bones. There's various rotator cuff pathologies. Chronic pain, I've had shoulder pain for months. I mean, that's a little more complicated trying to tease out what that is. Also trying to figure out if it really is the shoulder. Patients often confuse neck and shoulder pathology. Just going to relate a little story. I had a friend who was both a hairstylist and a manicurist. So doing hairstyles, with your shoulder elevated, trying to work on someone's hair. But at the same time, she also did pedicures. So she was constantly looking down as well. So she started to develop what she thought was shoulder pathology. She went and saw somebody who did some physical therapy, had it worked up. They actually did surgery on her shoulder to fix her rotator cuff, and her pain didn't get any better. So then they went looking at her neck, and it was actually a C-spine nerve root compression that was causing her shoulder pain.
Wow.
So ended up having to have surgery on her neck as well. And unfortunately, her condition didn't go well. She ended up with chronic pain and complex regional pain syndrome and some other stuff. But my point here is that sometimes it's really hard to tell the difference between neck and shoulder, especially when you get, that trapezius spasm going on there. Is that because of your neck? Is it because of your shoulder? Who knows? So often it's really hard to kind of tease that out. Other medical illnesses can cause shoulder pain. We all have heard of acute coronary syndrome, somebody with chest pain radiating to the shoulder or arm. A aortic dissection can radiate there. Pulmonary embolus can present with shoulder pain, pneumonia, pneumothorax, malignancies, also with nerve root compression and that sort of thing. GI disorders. If somebody has a bleeding peptic ulcer, they can get some abdominal pain that'll radiate to the shoulder. Ruptured ectopic. That's always a board question, radiating to the shoulder on that one. Shingles. People may have pain in their shoulder for days before the rash shows up. We've all seen that, where people come in with pain that you can't explain, and then a few days later, shingles shows up. Various arthritis syndromes can also refer to the shoulder. So how do we start figuring it out? That's kind of hard. So best way to tease out anything when you're trying to figure out a diagnosis is start with your H&P. So Joe, can we go over that a little bit?
Absolutely. So patients can develop non-traumatic shoulder pain, like you mentioned, but when there's an injury, it's important to ask about the mechanism of injury to let you know what sort of forces were involved and what kind of an injury to suspect, kind of hone down your physical exam as a result. So, for example, with twisting type injuries, you tend to think more about rotator cuff or possibly a dislocation. With falls, fractures are going to be more likely with that sort of force. And then a direct impact on the shoulder, you're going to think about the AC joint. With RSI type mechanisms where, like you talked about with your hairstylist or manicurist, where there's no sudden force, but just kind of a continual working of the arm, sometimes in an awkward position or a position where the mechanics aren't the best. You can begin to suspect tendonitis or bursitis in those patients. When there's no mechanism of injury, that's when you have to think a little bit more about the referred pain type syndromes that you talked about, maybe from structures in the chest or the aorta or even the abdomen. Gallbladder pain classically can radiate to the right shoulder. And any real subdiaphragmatic process can radiate to the shoulder too on either side. Stuff going on with the spleen can go to the left shoulder, right upper quadrant processes can go to the right shoulder. And that's when you're going to have your physical exam be more general and include more than just the shoulder. You'll kind of listen to the heart, consider intrathoracic issues, palpate the abdomen. And then shoulders, because it's bony structures, you got to suspect malignancy. In some cases, pain that's worse at night, where patients really aren't comfortable whether they're moving or not. Think more about that sort of issue. Obviously, if there's a history of malignancy that's already known, your predictive probability is going to rise for something like that. When you're in that non-traumatic, possibly referred pain, you're going to ask a lot more questions. In addition to the shoulder pain, are you short of breath? Do you have discomfort in your chest, nausea, vomiting, diaphoresis, those sorts of things. If you're worried about a dissection, is that pain kind of tearing? Is it traveling from the chest into the abdomen? Those kinds of things. The next part after your history is going to be your physical exam. Always start with inspection, of course. Kind of hard to examine a patient with their shirt still on or the gown still on. So you want to expose the shoulder, look at the shape of the shoulder. If there's some concavity of the deltoid, you might consider that they have a dislocation. Clavicle is right under the skin for most people. Even big people have kind of an easy to see clavicle for the most part. And a lot of fractures of clavicle can be diagnosed just on physical exam. You move on to your x-rays, characterize it further. Every so often, a patient will present with their arm in a crazy position and immobile. They show pictures of luxatio recti in there, which indicates an inferior dislocation. The next thing you want to do is to palpate the structures of the shoulder, palpate the clavicle, and then range of motion. I find clues me into a lot of things sometimes too. So right after you palpate, have the patient move their shoulder themselves. A lot of times, if there's limitations, pain can limit your range of motion of your shoulder, definitely. And that's very non-specific. But sometimes, and we'll talk a little bit more about it, specific limitations of range of motion can also indicate a rotator cuff tear, where the patient's just completely incapable, let's say, of abducting beyond 90 degrees. I will usually do a little bit of passive range of motions, check the patient's active range of motion first, and then see, is it truly limited or are they able to move a little bit more? That's important for kind of beginning to suspect a frozen shoulder and somebody who really doesn't want to move their shoulder at all. Gently try to move it in all directions yourself. And sometimes you'll find it doesn't move, and that's how you diagnose a frozen shoulder. Of course, just like with any other orthopedic type thing, we want to do a neurovascular assessment. I mean, we tend to think of bones and tendons and bursa when we think about the shoulder. But again, neurovascular compromise is going to be a reason for a lot quicker referral, an emergent referral, basically, right? So you want to make sure that you go all the way down to the hand and the fingers, palpate for pulses, make sure the sensation's intact all the way down to the fingers. Of course, you got that patient who comes in with a chief complaint of shoulder pain, and during your exam, they find a cold arm. That's going to change your differential quite a bit.
Yeah. One of my favorite things is to ask the patient to take their shirt off that you were mentioning. I find a lot of times if they just pull it off really easily, I'm like, okay, all right, this is probably not anything that's a big deal, or it's something that's referred and it's really not the shoulder at all. Those people that you actually have to help them take their shirt off, that's a little bit different. The ones that I find really the most challenging are the ones that can't move at all, because you can't do any of your specific maneuvers or provocative testing because you can't do any range of motion. They can't do anything, and those are the ones that we're either going to wait a few days and try and re-examine them again, or just say, you know what, it's ortho time. Let's send them off to ortho. Yep. We are going to talk about some specific maneuvers. There are 11 that are in this issue. When I was doing my editor-in-chief / peer review on this article, I actually went looking for specific maneuvers and I found over 30 of them.
Wow.
So yeah, it's great. Obviously, we can't really do all of them. I actually also went looking for sensitivity and specificity for them, and they're all over the place. They're crazy. A lot of them don't have really good sensitivity or specificity. Yeah. So why do a test if it's not giving you useful information? So we narrowed them down to 11 in this issue. Some of them are not that great at all either. Do refer to the issue to see what the sensitivity and specificity are on them, and then pick a few. All of us have our favorite ways of examining patients. I have 3 of them that I prefer. Joe, what are your favorites?
Well, let me start by saying I was really surprised by the sensitivity and specificity of those, some of it being pretty low. Just like a lot of things, we tend to settle into a pattern based on tradition and maybe not really know the accuracy of it. I was surprised by that. And just like anything else, if there are 30 ways to assess something, shoulder's a complicated joint, and there are a number of structures in there that need to be. But the reason why there are so many is because no one of them is perfect. If we had 2 perfect shoulder tests, there would only be 2. To me, that opened my eyes. I like the empty cairn test for supraspinatus tear. I was pleased with the 88.6% sensitivity, but the 58.8% specificity, like only half the time it indicates that there's a tear. I thought it was a lot more accurate than that. Cross-body abduction for impingement, the kind of so-called SCARF test, sensitivity specificity for that is only in the high 70s, but I think it's a good way to assess for that subacromial impingement of the supraspinatus tendon. The push-off or the Gerber-Listoff test for subscapularis, it's rarely an issue, but sometimes that patient has that achy pain kind of posteriorly, and it's actually nice to sort of substantiate that might be coming from the subscapularis. That's a good test for that. 100% specific, yay, but only 17.6% sensitive. Oh my gosh. And then assessing internal and external rotation, you can do it with the arm by the side. It's a little bit, I guess, less painful for the patient than abducting all the way to 90 degrees. Once you get that 90-degree position, I guess you call it the hornblower's test, right? And I find I can do that a lot of times with the patient's arm down by their body, just resisting internal and external rotation and seeing if that makes the rotator cuff anyway. But then the hornblowers actually looks like a really good test, specifically if you're looking for infraspinatus pathology, 93% specific, 100% sensitive. So you added those in. I thought that was fantastic to see the sensitivity and specificity in there.
Yeah. So I've spent a while going through and looking at all of them and trying to come up with the sensitivity and specificity. And I too was shocked by most of that.
Yeah.
That here we are doing all these tests and they're not as good as we think they are. My favorite is also empty can. I like the lift off where you have the arm behind the back in a handcuff type position and ask them to try to lift their arm up off the back. And then also the horn blowers with the external rotation. I try to also get really good range of motion in every plane that a shoulder moves. Doing that, usually can get a sense of what's going on with the patient's shoulder. But you know what? If most people have more than one injury, if we're talking about a rotator cuff. So sometimes you end up with information that's not all specifically pointing to one injury. So that makes things complicated too. A useful thing for these tests, though, is also doing serial exams. So if you have somebody that you're following up, say in a workman's comp type setting, doing the test every time they come, and if you can show that they're improving over time. So that's a useful thing too for these tests. Let's move on to some diagnostic studies. Most patients will have x-rays. Some of the people you can get away with doing x-rays, you get a history, you do a physical, and it's clearly some sort of rotator cuff tendinopathy. You really don't need to do x-rays in an urgent care setting for those people. Honestly, though, a fair amount of them are looking for x-rays, and sometimes you need to do x-rays before you make the decision to send them to orthopedics. So most patients will end up having x-rays. Proper views, super important. I can't tell you how many times I get back x-rays that they only did 2 views, which is not really helpful. You need to make sure you have the 3 views. And this is also supported by the American College of Radiology. You want to do an AP view. You want to make sure you do an axillary view, and you want to make sure you do a Y scapula view, because that'll make sure that you get a 3D vision of what's going on with that shoulder to make sure that there's no subtle dislocation. Some of those you'll only see on a Y scapula view, so please don't eliminate that. If you're looking for soft tissue injuries, you think it's a rotator cuff type thing, plain fills probably aren't going to help you much. Might help you if there's some arthritis going on in there, so you got some ideas that there's something going on. But MRI is really the study of choice in this situation, gold standard according to the American College of Radiology again. If you're suspecting a clavicle fracture, you want to do an AP and a serendipity view. Serendipity view, they generally have the patient lean forward a little bit so you can get a little bit more of the, also not really a 3D, but more of the aspect of the clavicle that you may not see in a regular AP view. You want to consider doing both clavicles so you can compare. A lot of times if you're thinking about an AC injury, it's useful to compare one to the other. If you're worried about, is this arthritis? Is this some sort of chip fracture? Is there a separation? Comparing to the other is useful. You can do a scapular or a Gresci view if you think you have a posterior dislocation, and also a Zanka view, which again is a different location, a different positioning of the clavicle for getting a better shot at the AC joint to determine if separation exists. Some people recommend for AC separation doing a weighted view where the patient holds on to weights with their arms to see if you can get that separation. Generally not something we do here in urgent care, but something surgeons may look for, or if you do have the capability of doing that, it might be a useful thing to see if there's any subtle separation that you might not pick up on a regular view. CTs are useful for surgical planning. Again, probably something that we're not going to do in urgent care, but just to know that it exists. So, Joe, we talked about some imaging here. Let's talk about specific injuries, specifically clavicle and scapula fractures.
Sounds good. Clavicle fractures make up, it's estimated, 45 to 60% of all shoulder fractures. It's the most commonly fractured bone in children. You talked about the importance of getting 2 views, sometimes a single view, you might miss it. So it's important to get it from that 2 perspectives and also let you characterize the displacement better by doing that. In terms of physical exam, look for skin tenting. Most clavicle fractures are treated conservatively, but if you have a fair amount of skin tenting by one of those underlying fragments, that's going to require a little quicker orthopedic referral. I can't say I've ever heard of the bone actually poking through the skin if it's not already an open fracture to begin with, but you can get skin necrosis in those situations where the skin's stretched over that displaced clavicle fragment. There can be complications from poor healing, so orthopedic follow-up is important. You can have malunion, non-union, dysfunction of the shoulder if it heals poorly. They say that pseudoarthrosis, where there's a poor junction of the two bones together, where it actually flexes with arm movements, occurs about 5% of the time. And even though it may not be involved in the fracture itself, if you have a lateral clavicle fracture, you can get accelerated AC joint arthritis from those lateral clavicle fractures, and it happens up to 6% of the time. These are usually managed conservatively. And I can remember the days where we used to do figure eights for all of them, like backpack strap kind of thing coming across the shoulder, crisscross in the back. We tell patients, you can't take it off ever. You have to wash and put deodorant on with it on, because as soon as you released it, that traction, which it was supposed to be applying, would be released. But there's been studies that show that treating these patients with a sling is fine, and that the outcomes are very similar. I will say occasionally I see a patient who's actually more comfortable in a figure eight than a sling, because it does apply a little bit of subtraction on it, and they may be uncomfortable with the degree of displacement. I can't remember last time I used it, but as I was making that transition from figure eight to sling, I remember there were some patients where figure eight seemed like it was better. And again, you're not trying to permanently immobilize it till it heals, but they're just more comfortable with that type of a support. Scapular fractures, these are usually high energy type injuries. I'd have to say, in my experience, I haven't seen many, maybe 6 or 7. And I'm thinking back, almost all of them came from people going over the handlebars of their bike and landing directly on their scapula onto something hard like rock or the ground. Because of that, you're going to want to be sure that you consider and examine for more extensive injuries like the head and the neck, and then consider intrathoracic issues, because it's pretty hard to get to the scapula that ends up breaking it. That force could be transmitted and you get rib fractures or pneumothorax, and sometimes even a delayed pneumothorax. So you have that patient you saw a few days ago with a scapular fracture. Now they're dyspneic. You get that chest x-ray, look extra hard for a pneumo in that case, in addition to rib fractures and other injuries. Scapular fractures are classified according to their anatomic location, but it's the degree of displacement that really dictates their management. Similar to clavicle fractures, they're being operated on more and more. So it's good to get an orthopedic opinion. Doesn't have to be urgent, but scapular fractures used to be managed with benign neglect, and now they are operating on them more and more if there's moderate or greater displacement. In our realm, in urgent care, you want to immobilize them, a shoulder immobilizer, possibly a sling if they're more comfortable in that. And then a lot of these patients we're going to send to the ED. The scapula it's hard to image with x-ray. I mean, you can get an AP view and kind of an en face sort of side. It's almost like a scapular Y view where you can look at it lengthwise. But CT is a useful tool, particularly to the orthopedist, to determine what they're going to do. And also, if you're concerned about intrathoracic injuries, a lot of these patients are going to be gone. Moving more distally, Trace, can you tell us about proximal humerus fractures and shoulder dislocations?
Well, actually, I just want to make a comment on the scapular fractures. The amount of force required to break a scapula is pretty significant. You really, really got to be diligent about looking for those other underlying injuries. I actually had one, oddly enough. Every time I do one of these, like a couple weeks later, I find something that was supposed to, we talked about how rare it was. And I actually had a kid, he was like a 13 or 14-year-old who was a football player. He was a quarterback, and he had been tackled with significant amount of force and was having shoulder pain for over 2 weeks before he finally presented to urgent care. Wow. Because his mom said he was having trouble throwing the ball because it was painful for him. He was still playing for 2 weeks, but he was having some difficulty with it.
Wow.
And I couldn't believe it when I saw that x-ray. I mean, it wasn't really that displaced, but he had a scapular fracture. I'm like, are you kidding me? You were playing football all the time?
Wow.
So I didn't want to send him to the ED because it had been already 2 weeks. I figure I'll just put him in a sling and send him to ortho. So we did that, and we told mom I salivate, take some ibuprofen as needed for pain. And as he's walking out with the sling on his arm, he goes, so I can go to football practice tonight, right? No, you can't.
Wow.
Yeah, I've only seen 2. You said both are bicycles. Both of mine were football players. Think about that for mechanism of injury if you see something like that. All right, so on to proximal humerus fractures and dislocations. Humerus fracture are generally fractures that are proximal to the surgical neck are considered shoulder fractures. 75% of them occur in patients that are greater than 65. I was in my mid-50s when I broke mine, so it is what it is. Generally, thoosh, fall on an outstretched hand, and usually outstretched elbow as well, to get that force that goes up and basically jams the humeral head into the socket of the shoulder. There is the near classification. There are 4 parts of the shoulder that fracture in sort of a specific way. The specifics are kind of beyond our scope, but one part means there's just 2 pieces of the fracture. And these are usually minimally displaced and they heal with just conservative treatment, just a sling and ice, and they do well. 2 parts, 3 parts, and 4 parts usually need surgery to pin those pieces back together because the concussive force that causes those fractures generally displace them. There's generally a lot of non-union, generally a lot of arthritis that'll occur if you don't fix them. They will have significant loss of range of motion afterwards if they're not repaired. So you want to make sure that those get referred to orthopedics in a timely fashion. You don't want them to see ortho 4 weeks from now. You want them to see them within the next few days. Don't really need the ED unless they're having severe significant pain or if they have any kind of neurovascular compromise. But like I said, you do want to get them into ortho within a few days. Urgent care management would just be a sling and make sure pain management. In these things, you really, really want to make sure you have a safe discharge plan. Again, most of these patients are over age 65. If it's their dominant arm, they're not going to be able to feed themselves. They're not going to be able to take care of themselves in the bathroom or bathe. They may have difficulty getting out of a chair because they can't use both arms to help support themselves to get out of the chair. So you really want to make sure that there's some sort of safe discharge plan at home. If they live alone, they may not have the help that they need. So ask about that. Complicated injuries, fracture dislocations, any neurovascular compromise require more urgent ortho evaluation. So again, these are the people you want to send to the emergency department. Sternoclavicular joint dislocations. I actually wrote when I made my little outline for this that I've never seen one. And then 2 days later, I had one in the urgent care. A gentleman who was involved in a domestic had gotten pushed in his upper chest very hard by an assailant, and he hit a wall very hard. So the force of him stopping abruptly with these hands pushing on his chest actually caused a sternoclavicular joint dislocation. He had some arm numbness and a really significant amount of swelling. He was very uncomfortable. I sent him to the emergency department for a CAT scan where he correctly had a sternoclavicular joint dislocation. It was actually sent to the trauma center for further evaluation. Again, high energy is required to do this. But if you think about your anatomy, right under there is all your major great vessels. So you are really at high risk for vascular injury. If you suspect this, this is an automatic ED referral. If you're interested in more details, review the article on that one. AC separation, falling directly on your lateral shoulder can cause that. One of 2 things are going to happen when you do that. Well, one of 3 things. Either you're not really going to hurt anything, or you're going to have a clavicle fracture, or you're going to have an AC separation. More common in athletes when they fall. Baseball players, soccer players who are diving for things can land directly on their shoulder and cause that. For AC separation, we've got the Rockwood classification. Again, we have types 1 through 6. 1 through 2 are generally conservative, and these you may not even see on X-ray because there may be little to no separation. This, again, we were talking about with the weighted X-rays. You might open it up and be able to see it a little bit more. The treatment for these are going to be very conservative with a sling and rest. Others may need surgery if they're a higher grade of separation. Again, most of these people are athletes, so you want to make sure that they're taken care of properly so they can get back to play and don't have any chronic concerns that are going to take them out of play permanently. So these people, you want to make sure they follow up with orthopedics or sport medicine. Again, stress review is maybe not so necessary in urgent care as something orthopedics is going to do, but if you have that capability and you're a very high acuity urgent care, might be something you're going to do. Glenohumeral joint dislocations, again, mostly anterior, the ones that we're going to see, rarely posterior or inferior. Those are very hard to reduce, so those are going to want to go to the ED with those. Anterior, very treatable in urgent care. Others, again, ED. And if you have a fracture dislocation, you're going to want to send those people to the ED. You know, I used to think that, shoulder dislocation, ED. How many times have we brute force these people trying to get their shoulders back in, even with sedation? But now there's a lot of good reduction techniques where we can actually do these in the ED, which we're going to talk about again in a little bit. Joe, can you do some pain control? How should we control these people's pain in our urgent care center?
Pain control. All these patients are in pain. And as far as analgesia, you've got your basics, acetaminophen and over-the-counter and prescription NSAIDs, your full armamentarium. Of course, NSAIDs are so commonly used. We just need to consider those patients where you might not use them. Older patients, patients with history of ulcers, that kind of thing. They're not benign meds, but super useful in many cases. We are in an era where we are sparing opioids, and they might still be required for severe pain. Obviously, patients with fractures, if they're in a lot of pain, it's important to just provide a short supply of pain medicine, maybe 3 days or so. There's some data, it's hard to say, but observational data shows that patients taking opioid pain meds for more than 5 days have an increased risk of long-term use. It may be because they needed them for longer than 5 days in the first place, but minimize the risk by prescribing a short amount for those whom you do prescribe opioids for. And those are going to be the patients with more severe pain. Some of the opioid sparing strategies that we have for the shoulder include using lidocaine patches. Actually, they might be helpful in some situations. And then I'm doing this more and more, having patients take ibuprofen and Tylenol together. We've been having patients kind of alternate them for fever control in their kids or themselves for some time. And I can remember being educated that they could not be taken together at the same time. But there's evidence that they can be taken together at the same time, and some study evidence that they're almost as strong as something like hydrocodone and acetaminophen. So ibuprofen, acetaminophen, hydrocodone, acetaminophen, similar analgesic potency, and you're not giving an opioid at all. Interestingly, I think the maker of one of the brand name over-the-counter ibuprofen products now has a combo acetaminophen ibuprofen pill, kind of low dose. You got to take a lot of them, and having patients take the two together. If one or the other works, then great. You don't have to, but they could consider taking both together. And in some patients, it'll be more potent. Intra-articular lidocaine can be used. It's not used so much for ongoing pain control in a patient with a shoulder problem, but if you're going to do a reduction, it can help facilitate the process. There's a Cochrane review cited in the issue that talks about pain control and reduction success being similar with intra-articular lidocaine compared with using IV agents to do the reduction. So useful tool in some situations. A lot of times you don't even really need it. If you do use the intra-articular lidocaine to help with the reduction, then the patient will get some ongoing pain relief from that, which is good. But most of the time, just reducing it reduces their pain quite a bit too. So the key advantage of reducing it is not only getting the joint back, but pain relief. When you're using intra-articular lidocaine, it's important to pick a formulation that does not contain epinephrine. And also you want to avoid preservatives. So it should be a single-use vial, not drawing the lido from a multi-use vial. Obviously sterility concerns, but even if you're the first one to pop open a multi-dose vial of lido for a shoulder, the preservatives can cause some issues with cartilage in the joint. And then that section of the issue talks a little bit about the use of steroids, and we'll talk more about that when we talk about treatment, but steroids are really to be avoided. Don't consider them analgesic in patients with shoulder injuries at all. How about reducing dislocations, Tracy?
Oh, one of my favorite topics, because this is something, once I learned how to do some of the relaxation techniques, I really enjoy doing it. And patients are very happy that they didn't have to have a trip to the ED. They didn't have to have any sedation. Usually my staff is in awe that I was able to do this. And face it, there are very few things in urgent care we can instantaneously fix. Mm-hmm. So that's really a good feeling when a patient walks in such distress and they walk out with a smile on their face. So one of my favorites. So all techniques, the goal is really to free the humeral head from the anterior inferior glenoid space and relocate it into the proper position. The problem with this is once your shoulder joint is out of place, all of the other muscles that are supposed to be holding your shoulder in place are now in spasm, which is resisting proper relocation. So most people, it'll be a little difficult to get that in because your body's resisting it. Traditionally, we've used the traction counter traction technique. I don't know if anybody's ever worked in the ED. They've seen this where you take a sheet and wrap it around the patient's chest and shoulder. Somebody pulls the arm, somebody pulls the sheet in the opposite direction. Requires a fair amount of strength, and it's pretty uncomfortable. And basically, this is just brute forcing to try and overcome that muscular spasm that's going on there. Most of the time, you need some sedation to do this, and now the patient is stuck recovering from sedation. They have to be there for a few hours. They can't make any medical decisions or drive their car for 24 hours. And obviously, this is something we can't do in urgent care. So people have tried to find other ways to avoid this. No matter what type of reduction you do, 5 to 10% of the time, this will fail and the patient will need to have reduction in the OR. And again, that failure is usually due to that severe muscle contraction that's preventing you from relocating it. Multiple techniques can be required, so I would strongly recommend you learn a few of them. So if one doesn't work, you can switch to another. Relaxation techniques, most commonly used in the urgent care, and there is absolutely no reason why we can't do this in urgent care. Once you have reduced the shoulder, you want to immobilize it immediately so that it doesn't pop out again. And then you want to do an x-ray to confirm that it's in the right place, that you did successfully reduce it, and make sure there are no fractures afterward. All of these people should be referred to orthopedics afterwards to make sure that all their muscles and tendons and everything are all intact and they're not at risk for redislocating. Again, know a few methods well. You can look it up on YouTube. If you go back to the issue, there's some links in there that'll help you out. My personal favorite is what's called the Cunningham technique, where you have the patient sit upright in a chair. I call it yoga for shoulder reduction because it's all about relaxation. You have the patient sit upright as much as possible. I have them picture themselves in their happy place, be it on a nice beach or relaxing in a relaxing environment, taking some deep breaths and trying to relax all of their upper body muscles. And then you're going to try and massage first their trapezius, then their deltoid, and then their biceps. And you're going to do this over and over, trying to encourage them to melt into the floor. And by doing that, you're going to release those muscles that are being very tight and tense. And with some rotation and some manipulation of that shoulder, it usually pops right in. It takes about 10 minutes, maybe less. And it works very frequently. Honestly, I've never had it fail, and I've done it probably 15 times. So very useful. Scapular manipulation. In this case, you have the patient lay face down on a stretcher with their arms hanging down towards the floor, and you want to massage and sort of manipulate the scapula, which will again release those muscles and allow that humeral head to pop back into the glenoid fossa. By doing this article, I found the Davos technique, which I thought was really interesting. Even if I explain it, it's not going to make sense unless you actually look at some pictures. Basically, you're going to have the patient sit in a stretcher with the head upright. You're going to tie their wrists together around their bent knee and slowly put the head of the stretcher backwards so that they're providing their own traction on their shoulder. And eventually this will pop in as well. And I haven't tried this one yet, but this looks really interesting. I think I'm going to try it. Joe, what's your favorite?
I learned the Cunningham probably 4 or 5 years ago. And like you, it works almost all the time. It takes a little while, but it's super cool to have this happen. And it's actually pretty comfortable for the patient versus some of these other things. If I'm having difficulty with it, the one thing I will do is have a colleague come or a nurse or an MA and do some scapular rotation. I find that it doesn't work sometimes if the scapula is, if you're looking straight at the patient's back, it's rotated kind of medially, and pushing down on that inferior edge of the scapula can facilitate that technique. You can actually reduce the shoulder just by doing that, they say. I have a colleague who does the Davos on just about every patient that comes in and tries that and has pretty good success with it. He actually carries around duct tape to duct tape their wrists together and then puts it over. He has his bag of tricks. He's got some duct tape in there. I don't know what else he uses it for, but I know he uses it for that. I have another colleague who has really good success with non-sedated awake reductions, doing a combination of abduction to about 90 degrees and externally rotating. He says it's kind of painful for them and it's facilitated by analgesia, but they don't need sedation. He says it works almost all the time, but I think it's more painful than the Cunningham. In the ED, if I actually get to the point where I need to do sedation on a patient, for me, the technique that works the best is the Spasso technique, where you flex to 90 degrees and externally rotate. Kind of similar to that adduction and external rotation. I mean, almost all reduction techniques are going to involve some kind of external rotation and mobilization of that humeral head that's out of place to some degree, and then externally rotating. The idea of traction, I don't think is so important, but yeah, those are my faves. I think I'm supposed to talk about overuse syndromes now. Let me start by saying that when we see patients with shoulder tendonitis, I think for a long time, maybe not at the first visit, but sometimes at the first visit, the inclination is to provide steroids, that corticosteroids or fix all of these things. And there's really no evidence of those helping. Talk a little bit about using intra-articular steroids as we go along here, but systemic steroids, parenteral steroids, either IM or oral steroids, really tons of increasing evidence about how harmful these are. And in the absence of any evidence to show that they help more than the other things that we have to do, really should not be using them. Talking about the specific entities, one of the more common ones that we see is subacromial bursitis and shoulder impingement syndrome, reported to be 44 to 65% of the reason for primary care and orthopedic office visits for patients complaining of shoulder pain. We don't have any specific urgent care data, but probably similar. The goals of treatment are pain relief and resolving the mechanical impingement problem that causes the issue. Interestingly, there's not a lot of study evidence and there's no consensus on the best management of this. So we have our usual kind of anti-inflammatories and physical therapy. Again, beware of NSAID side effects. May not be that patients actually need anti-inflammatory. It's just an analgesic. So in those situations where they're not going to tolerate NSAIDs, you could recommend acetaminophen. And what I find more and more, I think acetaminophen is such a safe medicine, reasonably effective. It's not super, super strong. But unfortunately, I think most people's experience with it is they have a headache, they take acetaminophen, and the headache goes away, and they don't have to do anything beyond that. When people have ongoing pain, it's a little bit harder, I think, in people's minds to think that they're going to take acetaminophen around the clock. It only lasts 4 to 6 hours, choking down a lot of tablets for ongoing relief. And so I'll usually recommend the longer acting acetaminophen. They come in 650 capsules or tablets, and you take 2 of them every 8 to 12 hours. Sometimes it's marketed as arthritis formula, and people get confused because they say, well, I don't have arthritis. But the idea of having arthritis is you have ongoing pain. And so for patients with these, painful conditions, I'll recommend that to them if they can't tolerate NSAIDs. In terms of intra-articular steroids for this particular disease entity, studies show that any benefit is really minimal and short-lived, so really not worth it to do. Interestingly, this is one of those disease processes where there's been some studies using intra-articular NSAIDs, good old ketorolac, as well as a couple of other agents that aren't available in the U.S. have been studied. It is less expensive and has fewer side effects than intra-articular steroids, but not super effective. They could be an option in that patient who really needs a little bit of extra pain relief. Bicipital tendonitis, this is discomfort of the proximal biceps tendon, probably inflammation, maybe just a tendinosis rather than truly inflamed tendonitis. Similar approach with NSAIDs and physical therapy. This is one of those conditions where there may be a little bit of evidence that injecting a steroid into the area might help. The issue cites a trial of 15 patients. And they said in that study that 40% had complete pain resolution and restoration of shoulder function. So something you consider, maybe not at the first visit, but that patient with a stubborn problem that's not getting better as fast as your other patients with similar problems. And then there is a surgical treatment for this if impingement of the biceps tendon in that subacromial area is an issue. But the orthopedist is going to try conservative measures for several months, maybe up to 3 months before you even consider that. Rotator cuff syndrome is really common. It's estimated that more than 90% of patients with acute shoulder pain have some degree of this really common occupational issue. The manuscript cites heavy work with the shoulders like construction workers, rock blasters, bricklayers. But you'll see this in patients who stock shelves or work at a checkout counter, any kind of repetitive shoulder movement. Even people who have bad ergonomics working with a computer can develop rotator cuff syndromes. Interestingly, for such a common problem, there's really no high-level evidence to demonstrate our best approach. So rest, NSAIDs, physical therapy, again, there was a study using kinesio tape. You see a lot of athletes wearing this, and honestly, I don't know if they're just trying to prevent injury or they feel like it improves their performance, but at least for rotator cuff problems, kinesio tape does not seem to be very helpful. There's no study evidence cited in the issue about the use of intra-articular steroids for rotator cuff syndrome, but they do cite a study that compares plasma-rich protein and steroids, and PRP was a little bit superior to intra-articular steroids. That's going to be done by PETA, so we're not going to be doing that in urgent care. Or I see actually a lot of these PRP clinics are popping up where you can go and get a PRP injection for patients with chronic pain or other issues. The final similar disease entity here is adhesive capsulitis and frozen shoulder. Frozen shoulder is a great description of this. They just cannot move and you can't move their shoulder. But adhesive capsulitis might be a bit of a misnomer. There's really not adhesions that form between the capsule and the bone of the shoulder, but it's more of a contracture of the joint capsule and synovitis that's involved here. Affects about 10% of the population. And in patients with diabetes, the risk is increased threefold, so a little more common in our diabetic patients. This is the one shoulder problem where there's some guideline recommended treatment that includes intra-articular corticosteroids. There's some study evidence that shows improvement, particularly in the short term, but it seems like that levels off. And by the time you get to a year, treated and untreated patients are about the same. This is a really painful condition, aggressive mobilization you don't want to do. Years ago, they used to take patients to the OR, put them out and mobilize them under anesthesia. Those patients ended up doing worse. The other surgical intervention is a capsular release, and results of that are not really that good either. So physical therapy is going to focus on gradually restoring these patients' range of motion with what they do in their clinic, as well as in some home exercise type stuff. Similar to lateral epicondylitis, which seems to have a natural history, seems like that's the case with this too. There's several months of pain, several months of stiffness, and then most patients are going to recover, but it may take up to a couple of years to do so. So you want to focus on comfort and improving their function during that time. Just kind of a bummer of a condition. How about cutting edge for shoulder?
All right, we can talk about that. So ultrasound is pretty useful to diagnose dislocations and relocations, kind of saving you from having to do those x-rays and reducing radiation exposure. Ultrasound is kind of new to urgent care, but is starting to make its way into our arena. So if you have that available to you, it might be useful. It also is helpful for intra-articular injections. So if you're going to do the lidocaine that we were talking about for pain control, or if you're going to do those steroid injections that we said you shouldn't do,
Mhm.
it might be useful for that. And also, as I said, should facilitate reduction. That might be something that's useful. Clavicle fractures. For years, I was like, oh, yeah, your clavicle's broken. Have a sling, follow up with your PCP, have a nice day. But now we're really starting to refer more and more of those, especially if they're displaced to orthopedics, because they are starting to repair more and more of those, realizing that patients do better once those are repaired. Joe, can you talk about some points on fractures?
Yeah, you bet. So thinking about collarbone fractures and your imaging of those, make sure you get those two views. You want that AP and serendipity view. I love that name. There's no way to get 90-degree views like we like to on most long bones. So that serendipity view, which is about 30 or 40 degrees cephalad, is helpful. Just gives you another perspective. Most clavicle fractures are going to be treated conservatively, but like Tracy mentioned, there's a recent trend toward operative intervention. These used to be screw and plate fixation, which would kind of show, you can't get behind the clavicle to fix it and hide your hardware. So a lot of times you trade your bump of clavicle fracture for some hardware that was kind of visible underneath your skin. There's some new devices that actually are kind of like small intramedullary rods that can fix these clavicle fractures now. And it tends to be a pretty specialized procedure. We have a couple of orthopedists in our community that specialize in this. And so could somebody who is really active or their sports dominant arm, or even in general orthopedic follow-up to see if they're a candidate for that is not a bad idea. Scapular fractures, again, remember to examine for associated injuries because these are high energy type fractures, and referral to the ED is going to be a good idea for most patients to get that CT for operative planning, and then as well to be a little bit more sure that there's not an occult intrathoracic injury or C-spine or head injury. We can do C-spine and head injuries in urgent care. I think we feel comfortable with that, but intrathoracic stuff's a little bit harder, especially subtle. The near classification, I remember trying to memorize that a bunch of times, the very specific part, but the easiest way is if the humeral head's broken into two pieces, it's a 2. If it's 3 pieces, it's a 3. It does involve the tuberosities and all that kind of stuff. But when we're communicating with an orthopedist, specifically for those more complicated ones, to try and count the fragments and let the orthopedist know it's a 3-part or 4-part fracture. And sometimes they'll see the patient a little bit more quickly than if it's just a routine, uncomplicated humeral head fracture. Most of these are going to be managed non-operatively unless they're multi-part, or if there's any displacement, fracture dislocation, then that's urgent referral because that needs to be managed. AVN of the humeral head is really a devastating complication of these humeral head fractures and even humeral neck fractures. So referring to ortho, making sure that they get appropriate care is important. How about some points about dislocations?
Yeah, again, we were talking about x-rays. You want to make sure you get those 3 views, including the Y scapular. I wouldn't say frequently, but occasionally you can only see that anterior dislocation in that Y scapular view. So if you suspect it, make sure that that's the one that you look at very carefully. Anything other than an anterior dislocation should be sent to the ED because they're really, really hard to reduce and will definitely require some sedation beyond what we're capable of. Low-grade AC separations, generally managed conservatively with a sling and rest. Grade 3 and higher should have ortho-eval. Again, you don't really have to send them to the ED, but you want to make sure that they get some timely orthopedic evaluation. They will likely need surgical repair, especially because they're usually an athlete that you want to return to play as soon as possible. So you want to make sure that they have adequate follow-up. Younger patients are at greater risk for recurrence and disability from any sort of dislocation. So you want to ensure that they're not lost to follow-up and encourage them to follow up even if they're feeling better. A lot of times people who have had a anterior dislocation, you relocate them. Maybe they're self-pay or maybe they're young and think they're invincible. They will take that sling off in a couple of days and think they're good to go. So you want to make sure that they will get some follow-up. So please encourage them to do so. Do we have any points on overuse?
Yeah, I think, our mantra, rest, PT, NSAIDs, or acetaminophen, if a patient can't tolerate NSAIDs, holds here. Some degree of mobilization of the shoulder. We talk about rest, and that's from the heaviest activities and the ones where, reaching and overhead use where the shoulder mechanics are put most at risk for injury or irritating those injured structures. But it's important to maintain some degree of mobilization of the shoulder. If you just completely rest it and immobilize it, it's going to stiffen up. So sometimes patients need physical therapy to get them through that phase. And then frozen shoulder may be treated with intra-articular steroids. But again, with the mounting evidence of the harm of steroids in general, even intra-articular steroids, we want to avoid them for patients with overuse injuries, systemic, intramuscular, or intra-articular, because there's not a lot of evidence that they help. How about some pearls?
Yeah. Sternoclavicular injuries. Remember, we said they're an emergency because there's a serious risk of vascular injury. So if you find one or highly suspect one, you're going to want to send them to the ED. Not sure if I mentioned it earlier, but they're really hard to see on plain x-ray because of the plane that they're in. Your clavicle will almost be pushed in or slightly separated from the sternum. And that's something that's really hard to see in an AP or lateral film. So sometimes you may not be able to prove it, but if you highly suspect it, you want to make sure you send that to the ED. Intra-articular lidocaine is good for pain control if you're able to do that. Again, you want to use preservative-free lidocaine without epinephrine. Even better to do this if you have ultrasound, because that can guide you right into the joint and make it a little bit easier for you to do that. Shoulder reductions, no single method is better than the other. It's whatever you feel comfortable with and what you're skilled at doing. You may need to use more than one technique, so I strongly recommend you learn 2 or 3 of them and go with that. Don't feel bad if you fail, because 10% have to go to the OR for reduction, but it's nice to be able to try and save the patient an ED visit, an ED bill, sedation, and basically messing up their day and a half.
Definitely.
So if you can do that in the urgent care, that's a win-win. Redislocation is very common, so you want to sling them and you want to make sure that they get that orthopedic follow-up they need to prevent the long-term complications of chronic dislocation, arthritis, and loss of range of motion. So in conclusion, Joe.
Yes, when you're dealing with patients with shoulder pain, shoulder injuries, it's important to have a systematic approach that includes good history, know when to suspect that the problem may not be in the shoulder, that it's referred pain. Know how to do a thorough exam, have your go-to techniques and maneuvers, and make sure you assess the patient's neurovascular status. Make sure your x-rays are 3 view because it's a joint, really complicated, multiple bony structures coming together. Clavicle x-rays, you want to do 2 view. The care of fractures is largely driven by the degree of displacement and deformity. Certainly any damage to neurovascular structures requires immediate orthopedic referral. And then finally, overuse syndromes and other soft tissue injuries of the shoulder that don't involve fractures, you're going to do rest and NSAIDs initially, and then consider physical therapy if patients are recovering quickly.
Great. Well, thanks everyone for tuning into this episode. We hope you learned something new or reinforced your knowledge or inspired to read further. Maybe try something new to advance your skills. Look at this issue in print. There's lots more juicy things in there for you to glean some knowledge from, and a lot of links to videos and things to reinforce your knowledge and procedures. Next month's issue is ear infections, and we look forward to talking with you about that.
Take care, everyone.
I want to thank everybody for listening to this month's evidence-based urgentology podcast. Just a reminder that subscribers can go to evmedicine.net and read the full issue if you want more information, if you haven't already.
And if you're not a subscriber, head to the site, that's evmedicine.net, to check out what they have. If you subscribe, you'll get access to the article, as well as future articles and the whole archive of all past issues.
Look forward to seeing you there.